All right. Hello, everybody. Welcome to the IARS virtual education webinar. And this one is less really more for the brain in the ICU? We have received no commercial support for this webinar. And CME is available for this webinar to IARS members only. And here are the instructions for making that happen. And claim your maximum of 1 hour if you desire. Also, a plug for the upcoming IARS meeting. The 2023 annual meeting is in Denver, April 13th through 16th, combined with AUA and SOCA, which I think is relevant for this talk especially. So hopefully see quite a few folks there in Denver in April. With that, the abstract submission is now open, so please submit your abstract for the opportunity to present at IARS, AUA, and SOCA. And right now that deadline is December 2nd for the abstract submissions. Just in case you missed the last IARS meeting, there is an on-demand access to session recordings for IARS members, and you can find that at the website shown there. And then after this webinar, we'll be doing some sort of questions in the IARS Doc Matter community to continue the conversation about topics that get covered today. And importantly, for the Q&A session, so this will be at the end of the recordings, please use the Q&A button on the Zoom taskbar. That's how we'll collate the questions and we can fire them off to the presenters for the live Q&A session after the recordings. You will receive an email after this webinar with information about the CME, so look for that. And here is our lineup. So I'm going to just skip through this a little bit because I'll have some introduction slides for each. So for the first slide I just wanted to show is I think this really interesting quote back from 1959. Talks about, critical care. We care a lot of things about different organs, but we tend not to think about the brain as an organ in the same way that we think about the heart, the liver, and the kidneys. And that we think is a serious and perhaps tragic omission. We're going to cover some aspects with that today. Of note, as you can see, we cover a lot about brain dysfunction, whether it be post-operative or in the ICU. In this case, you have risk factors from the patients and then the critical illness themselves, the insults, the ICU environment, and then all the different things that come with being critically ill and in that ICU. And importantly, this doesn't just occur in the ICU, but it has long-term sequelae and likely some mechanistic connections there between both what's happening acutely in the ICU and the symptoms that we see afterwards. So acute effects, length of stay, cost of care, institutionalization, mortality, all bad stuff. No study has actually shown any benefit with acute brain dysfunction. And we talk about 4 million people surviving a critical illness and having all these deficits afterwards. Again, that's pre-COVID pandemic. And as we know, long COVID and long haulers COVID, or whatever you want to call it, it's gotten a lot of attention. And so I think we're going to see more and more of this in the future. So these impairments can be with cognition, it can be with physical function, and a lot of people have a mix of that, frailty, disability, psychologic as well. And most people don't just fall into one category. There's a lot of overlap on that Venn diagram. So our first talk is going to be by Dr. Michael Devinney. He is a MD and PhD at University of Wisconsin, and then residency and critical care fellowship at Duke. And he stayed on there as faculty since 2020. His primary research interests include mechanisms on postoperative delirium and cognitive dysfunction. And he's going to be discussing beyond chemical restraints, our sedation choices confining patient outcomes. Dr. Christina Boncyk did her MD at the University of Wisconsin and her residency there as well. Then fellowship in critical care at Vanderbilt, where she's been on faculty since 2018. Her research focuses on the effect of prescribing practices on long-term outcomes, and she's going to be discussing the potential threats hidden within the medication list. And our last talk will be from Dr. Christina Hayhurst, who did her MD from Arizona College of Medicine and then residency at Virginia, came to Vanderbilt for her critical care medicine fellowship and has been on faculty since 2015. She's currently the program director for the fellowship, and her research focuses on opioid-induced hyperalgesia and post-ICU pain and quality of life. And her talk will be Critical Illness Hurts, Even After Discharge. So with that, I'm going to stop sharing my screen and link everybody over to the webinars, the recorded sessions. Please type in anything you want answered into the Q&A, and we'll look forward to the live session at the end. Thank you very much.
Hi, everyone. My name is Mike Devinney, and I'm an assistant professor in critical care and anesthesiology at Duke. Today, I want to talk to you about how our sedation choices could impact patient outcomes in our intensive care units. These are my disclosures. I do receive funding from FAIR and the National Institute of Aging. My spouse owns an equity share in an employer that makes personal care products unrelated to this research or this talk. So we know that millions of our patients survive critical illness each year. However, many of them experience cognitive impairment and physical debility that causes severe decreases in their quality of life. And we need to find ways to prevent this by potentially improving how we provide critical care to our patients. In other words, we need to create patients that not only survive, but also thrive after critical illness. We know from the brain ICU study that many patients develop post-ICU cognitive dysfunction. In this study, they followed 821 patients and tested them with a cognitive testing panel known as R-bands, include a number of cognitive tests. It is at 3 months and 12 months after critical illness. What they found is that many patients have global cognitive impairment that is below age-adjusted norms. For example, in the older group here, over half the patients meet criteria for mild cognitive impairment, and about 40% of patients have global cognition scores around those with moderate TBI or traumatic brain injury. And 26% of patients had global cognition near the levels of mild dementia. This is concerning because only 6% of patients had any evidence of a pre-existing cognitive impairment before their hospitalization and critical illness. So what can we do to prevent post-ICU cognitive dysfunction? Well, unfortunately, we really don't have many ways to prevent it. We know that there are some risk factors that are mostly non-modifiable, such as increased age, baseline cognitive impairment, and higher burden of comorbidity. However, there may be some interventions that we could perform in an intensive care unit because we know that longer duration of delirium, longer duration of mechanical ventilation is associated with cognitive impairment after critical illness. And this is from the brain ICU study, where they demonstrated that increased days that someone spent delirious was associated with decreased global cognition at 12 months. This really raises the question, well, what can we do about post-ICU cognitive dysfunction? What if we could prevent delirium? And perhaps that would help prevent post-ICU cognitive dysfunction and improve the lives of our patients that survive critical illness. So to understand how we could prevent delirium, we need to first understand delirium itself. Delirium is a form of acute brain dysfunction that is really characterized by inattention, disorganized thinking, and alterations in awareness. And it can exist along a spectrum. Subsyndromal delirium typically is characterized by isolated deficits and inattention, and patients can have delirium that ranges from mild to severe, and it's sometimes difficult to pick up on patient interview if it's mild. We also, acute brain dysfunction can result in coma. Some of our patients that experience really this whole spectrum of delirium can intermittently progress into coma that is unexplained by other causes. And so we also need to consider this when we're assessing for delirium. Delirium really results from an interaction of precipitants and predisposing factors. Many of the predisposing factors, similar to post-ICU cognitive dysfunction, are not modifiable, such as advanced age and baseline cognitive impairment. The precipitants are pretty common, the things that we see in the ICU, such as sepsis, respiratory failure, shock, electrolyte disturbances, or postoperative care. And these underlying causes we can treat, but they often evoke an aberrant neurophysiology that results in delirium. And this aberrant neurophysiology is really the focus of ongoing research, because if we can find ways to prevent this, we could prevent delirium and potentially prevent its sequelae, such as post-ICU cognitive dysfunction. However, we have a long way to go before we get to that point. But I do want to bring your attention to several other factors that can result in delirium. And these are termed hospitalization factors, because these are things we do to patients in the hospital, in the ICU, that can precipitate and propagate delirium. This includes pain from procedures or hospitalization, invasive devices such as Foley catheters and central lines, immobility, polypharmacy, administration of psychoactive drugs, disrupted sleep and circadian rhythms, physical restraints, and lack of family presence. And if you think about it, there is one thing that we do to patients in the ICU that really can cause many of these hospitalization factors, and that is sedation. Sedation can mask pain, can lead to untreated pain because we don't understand that the patient's experiencing pain if we overly sedate them. It can lead to increased use of invasive devices such as Foley catheters, causes immobility. Sedation is a psychoactive drug that actually interferes with normal sleep and causes circadian disruptions. And sedation actually can result in the use of physical restraints more often than in unsedated patients. And sedation discourages from family presence because family don't like being around their loved one when they're sedated constantly and would rather interact with them. So I think we need to be careful in how we use sedation. And this is supported by many of the studies on sedation. And really one of the groundbreaking studies was the men's study in 2007 by the Vanderbilt group, where they showed that sedation with lorazepam versus dexmedetomidine resulted in greater amounts of delirium and coma. And lorazepam resulted in greater amounts of sedation. And here they show that dexmedetomidine is associated with greater amounts of delirium-free and coma-free days. And really, this first study suggested that sedation with benzodiazepines were harming our patients, and that was really the practice at that time. So it was a really important study. But I want to point out one element, that patients receiving dexmedetomidine, they often met their RASS goal, while the lorazepam patients tended to be more deeply sedated. And so this led to some further investigations of light versus deep sedation. And Miriam Trugeri and her group investigated this in an open label randomized controlled trial, and 137 ICU patients were randomized to light versus deep sedation. These patients required mechanical ventilation, and they found that lightly sedated patients had a significant reduction in their days of mechanical ventilation and their ICU length of stay, as shown here. They also measured PTSD symptoms and disturbing thoughts and memories from the ICU stay. And they found that deeply sedated patients had more disturbing memories, and they had a tendency to have more PTSD symptoms. So this is interesting, because we tend to think that sedation can help a patient be more comfortable during their critical illness, but in fact, it may be leading to greater amounts of psychological distress. Additional studies have also explored light versus deep sedation in relation to delirium and mortality. And this results from a multi-center longitudinal observation study of 628 critically ill patients that were mechanically ventilated for longer than 24 hours. They measured sedation intensity by calculating this sedation index, which was really the absolute value of their negative RASS score over time, averaged over time. And what they found is that higher levels of sedation index, or sedation intensity, was associated with increased 180-day mortality, and then also increased probability of delirium, as shown here, where delirium-free probabilities on the y-axis. And these are the higher levels of sedation, higher tertiles of sedation, and this is the lowest tertile of sedation. So lightly sedated patients tended to have less delirium, and they also had less delirium, and they had less 180-day mortality. And so this is a result of just an observational study. We don't really know if randomization to light sedation would cause this. There is a meta-analysis and systematic review that investigated this, or put together the studies that investigated this, and they did show that lighter sedation was associated with decreased mortality. And there was also a strong trend towards decreased delirium. So I think that we really need to strongly emphasize lighter sedation in our patients based on these results. And I think future studies need to also look at the effect of light versus deep sedation on post-ICU cognitive dysfunction. But how can we implement this? How can we actually achieve lighter sedation in our patients? I think we need to take a step back because sedation is really one element of how we practice critical care. And within that whole realm, they all interact. We need to find ways to keep the patient comfortable. We need to have the staff on board and on our team to help do this. And this really requires implementation of the ABCDF bundle, where we need to assess, prevent, and manage pain. This requires all team members doing this. We need to perform spontaneous awakening trials, have our nurses do this, so that we turn the sedation off, see what the patient does, give them the minimal amount that they need to be comfortable each day, because every day is a different day. We need to also perform spontaneous breathing trials where we can liberate patients from the mechanical ventilator as soon as possible. We need to use our clinical expertise to adequately administer analgesia and choose a sedative that is appropriate for our patients if they need it at all. And then we need to assess, prevent, and manage delirium. We need to achieve early mobility and exercise in our patients so they don't experience physical debility, as that also can lead to cognitive dysfunction. And then we also need to engage the family. And we need to encourage their presence, have them be there, as their presence is probably more comforting than any sedative that we can give our patients. And so to conclude, I just want to say that preventing delirium during critical illness is extremely important, as it can prevent many other negative outcomes, including longer-term post-ICU cognitive dysfunction. Early light sedation might help prevent delirium, and we need to target this in our patients. And it might also help prevent post-ICU cognitive dysfunction. And the way we can achieve this is by implementing the ABCDF bundle and performing patient-centered care to help us deliver less sedation and reduce delirium rates and improve outcomes in our critically ill patients. I want to thank you for the opportunity to present at this IARS webinar, and I'm grateful for the supportive environment I am in at Duke and for the funding sources that I'm lucky to have. And I look forward to all of your questions during the panel. Thank you.
Hello, I'm Tina Boncyk from Vanderbilt University, and my talk is titled Potential Threats Hidden Within the Medication List. I received funds through the Department of Anesthesiology, the NIA, and through consultant work with Sedona Medical. My talk today is not relevant to that work. To lay the groundwork as to why I find the medication list to be crucial to brain health among our critically ill ICU survivors, I want to highlight a couple of key points that we will go to further within this talk. Interfaces of care represent key time points associated with inappropriate prescribing. While it's often not feasible to eliminate all high risk or inappropriate medications, efforts to decrease their exposure also show benefit, and ICU survivors are frequently discharged on new inappropriate medications, the majority of which are initiated within the ICU. It is no doubt that ICU patients are complex. A patient admitted to the ICU today is more complex than ever, presenting with acute illnesses and frequently several overlapping chronic conditions. These involve complex pre-admission medication lists, especially when considering over-the-counter medications, drug-drug interactions, and management of medication side effects or adverse events in the setting of acute illness. In light of this, what home medications should be continued and what need to be discontinued or even reversed? While emphasis should be on the management of acute illness, patients can exhibit important withdrawal symptoms that can put that at immediate or downstream harm associated with the abrupt discontinuation of them. For example, discontinuation of home statins and antidepressants can put patients at increased risk for delirium or antidepressant withdrawal symptoms in the short term, and in the long term, increased emergency department visits and hospitalizations and even death, if permanently discontinued. It is clear that this is an important part of patient care And the country of Canada even agrees, having passed a law in 2008 mandating medication reconciliation practices following hospital admission. And this is data supported. Within a prospective study where pharmacists completed almost 1,000 medication reconciliations, discrepancies were identified in almost a third of all patients, with a third of those classified as serious or very serious in nature. Not surprisingly, these errors increase with the number of home medications increasing. So what are the risk factors for ICU medication errors? Well, they start with unverified pre-admission medication lists and include extremes of age and increased severity of illness, highlighting these complex patients and medication lists we see so often. There are also valuable modifiable provider risk factors. Inexperience, which often not always coincides with lack of knowledge, and sleep deprivation increase medication errors. And also important environmental factors that include frequent changes in medications or doses, likely related to fluctuations in care and illness resolution or decompensation, urgent care needs, nighttime admissions or discharges, and frequency of handovers. Oftentimes, providers are unaware of the indications for current medication regimens and may be apprehensive to adjust them following critical illness, which can lead to prolonged inappropriate medication continuation. So how do we identify what is an inappropriate medication? Well, my boss, Dr. Hughes, knows that whenever possible, I like to communicate in emojis like the geriatric millennial I am. So we want to really be in this bottom left corner with low-risk medications of high benefit and avoid the top corner, which are high-risk medications with low benefit. High risk and high reward or high benefit medications warrant contemplation. And the low risk but low benefit medications in the bottom right corner are represented by the straight-faced emoji, which is the look that I will give my residents or fellows basically when they administer these, a bit unimpressed. But what's more important is that when we highlight a medication, for the most part, it isn't in one category all the time, or even for one patient. For example, with acute illness, antibiotics can shift from high benefit to low benefit. Anticoagulants can shift from low risk to high risk. And even the over-the-counter acetaminophen, depending on the dosage, can cross into different categories. So we must be able to adjust with those medications. A great example of this that I hold of particular interest is in antipsychotics for the treatment of ICU delirium. A recent development, first described in 1978 for acute delirium, its use has significantly increased. We found at our institution about half of all delirious ICU patients receive an antipsychotic, with half of those receiving 2 or more different antipsychotic agents. And when we looked at their association with delirium continuation and in-hospital mortality, we found haloperidol and olanzapine were associated with an increased odds of delirium continuation or a lower likelihood of delirium resolution after adjusting for pre-specified covariates. Haloperidol and olanzapine were additionally associated with a higher hazard of in-hospital mortality. Now, I want to remind the audience that these are retrospectively investigated, so we cannot determine causality, but these were analyzed using daily transition models. So every day of haloperidol administration was associated with a higher odds of delirium continuation and an increased hazard of mortality the next day, suggesting these medications, in addition to not being of benefit to treatment, may also introduce harm. So to classify that in a routine ICU patient, these findings suggest that antipsychotics are of high risk and low benefit to patients. But what if this patient was instead agitated or pulling at their lines and becoming a threat to themselves or others? That situation is inherently different and may move haloperidol towards a high risk but high benefit medication after we optimize non-pharmacologic interventions, of course, which makes it important to classify this in the context of the rest of the literature. Several RCTs, including the MIND USA trial and the new AID ICU trial, comparing atypical and typical antipsychotics to placebo, have found also no benefit to delirium duration, days alive and free of the ICU, or days alive and free of the hospital between those that were randomized to receiving antipsychotic medications or placebo. But importantly, these RCTs found no harm as well, which may lead one to classify these medications as low risk, but also low benefit. So why did we see the results that we saw within our study, but these large RCTs did not see that? And I feel the answer to this is really within the prescribing practices. These studies demonstrated no harm because they had protocolized prescribing as well as deprescribing practices. Our real-world, real practice cohort showed antipsychotic medications were initiated early, continued for over twice the duration of the delirium episode, and importantly, continued in up to 20% of these patients at hospital discharge, which is not unique to our sample. The literature describes inappropriate continuation of antipsychotic medications initiated in the ICU as between 15 to 34% of patients that survived a hospital discharge. And when analyzing what the risk factors are for the continuation of antipsychotic medications, varying factors, including discharge from a surgical service, discharge to a nursing facility, age, and sex have shown significance within specific populations, but the strongest predictor, however, is merely the receipt of an antipsychotic medication while within the ICU. Now, this is not unique to antipsychotics. Looking at a cohort of older patient ICU survivors, 120 were sampled here, we can see that 76% of inappropriate atypical antipsychotics, 67% of inappropriate opioid prescriptions, and an astonishing 80% of non-benzodiazepine hypnotics were initiated within the ICU. Together, this emphasizes that medications initiated within the ICU for treatment of acute indications such as anxiety, pain, delirium, insomnia, or other disorders have frequently continued long after their intended indication. ICU discharge therefore presents for many patients a high-risk time period prone to medication transfer errors that have lasting impacts on patients. Improved understanding on the indications of these medications, the risks, and thoughtful consideration about risk benefits for each individual are essential to help decrease these medication errors. Discontinuing medications that are no longer indicated is complicated and requires an understanding of why the medication was started and what is physiologically occurring in the patient at the time of ICU transfer. It's not surprising that longer hospitalizations, which facilitate more exposure, are associated with more unintentional medication continuation, compounded by multiple providers who may be less familiar with the indication of each medication. But these decisions made at ICU transfer have lasting implications for patients. In a population study of over 1 million older adults discharged from an acute care hospital in Canada, antipsychotics, benzodiazepines, gastric acid suppressants, and respiratory inhalers were all identified as having high rates of inappropriate or undocumented indication for continuation and were refilled up to a year after a hospital discharge, amounting to costs of over 18 million Canadian dollars over that time period. But are these costs worth it? Unfortunately, they're not. Increased potentially inappropriate medications, in addition to increased drug costs, are associated with increased drug-related problems, healthcare utilization, and overall worse patient outcomes across all of these fields listed, including sleep disturbances, confusion, dementia, and cognitive impairment. As part of our multidisciplinary approach undertaken at the ICU Recovery Center, we identified within a population that had significant proportion of post-intensive care symptoms, every patient had at least one medication adjustment when seen by a pharmacist at their follow-up clinic, which included either a medication adjustment, discontinuation, or a reinitiation of a home medication. Expanding this to over 250 ICU survivors across 5 recovery clinics in Scotland, there was a finding of over 60% of patients that required at least one pharmacologic intervention, the vast majority of which were clinically significant and related to centrally acting medications, including analgesics, antipsychotics, and antidepressants. So great. We're going to focus on medication reconciliations. I've convinced you. What is really the best way to do that? Well, there isn't one. It's generally a combination. A systematic review illustrated that while a single component intervention, such as a pharmacist or resident initiative, was effective at decreasing inappropriate prescribing, a bundled approach was even better. Combining interventions such as staff education, medication reconciliation practices, electronic handover tools, and patient initiatives produced an almost 4-fold decrease in inappropriate prescribing. And this buy-in is important because while simply adding or discontinuing a medication may seem helpful, you have to have the patient's buy-in to believe you. They've often come in with these medications prescribed for a long period of time, and for better or worse have become adjusted to these medication regimens. Changes made during an acute hospitalization can cause confusion if they're not explained. And although elderly patients can often resume these outpatient medications even when told to discontinue them following a hospitalization, this study found that that is not the same across drug classes, as patients were more likely to take opioids even after they were told to discontinue them, and not as likely to take newly prescribed antipsychotic or antihypertensive medications that were added following hospital discharge. Looking forward, there are several steps to take towards improving medication regimens and optimizing care within and following ICU admission. Better characterizing short and long-term outcomes associated with medication classes across populations will inform prescribers. Without being able to associate a risk, many of these medications are continued far longer than their acute indication. There should also be an improved focus on patient-centered outcomes. Outside of mortality and hospital readmission, How do these medications impact patient independence and function? And finally, but more importantly, can we identify a bundle for high-risk medications, medication alternatives, or key points to intervene to ensure that our patients get the most benefit? I want to thank my mentors, the support from the Vanderbilt Department of Anesthesia and Research and Statistical Supports, my funding through the FAIR and SIB Center for their ongoing collaboration. Thank you.
Hi, my name is Christina, and I'm an Associate Professor of Anesthesia and Critical Care at Vanderbilt. And today I'm going to be talking about pain in the acute setting in the ICU and after discharge. To start with, I have nothing to disclose. The format of the talk will be to discuss the problem and scope of pain in the ICU. We'll go over some assessment and management strategies and then discuss the long-term outcomes of chronic pain. The SCCM, or the Society for Critical Care Medicine, recommends using the A through F bundle, and we'll be discussing A, which is the assessment of pain. The most recent updated definition of pain from the IASP in 2020 is an unpleasant sensory and emotional experience associated with, or resembling that associated with, actual or potential tissue damage. And it's important to keep this definition in mind because unlike blood pressures or heart rates or other objective measurements, pain in our patients is always going to be subjective, and different patients will feel different things based on their backgrounds, their risk factors, and their coping mechanisms. So it's something we need to think about in a slightly different way in the ICU. And unfortunately, we know just being critically ill is a painful condition. There's not only the tissue damage from your pathology, but there's all the procedures and maneuvers we have to do for monitoring and for treatment. And pain is not existing in a vacuum. It can stimulate your sympathetic nervous system. That can lead to hypermetabolic catabolism and actually be an immune modulator as well. It can also contribute to a cycle of worsening delirium and agitation. So you can see here elements of just routine ICU care, such as turning or suctioning of the endotracheal tube, can lead to increased pain. That in turn can lead to worsening delirium. Undertreated pain, or sometimes even opioids to treat pain, can worsen delirium, which can lead to agitation. A lot of times that agitation is treated with more sedation, and thus you have a less interactive patient. They can't tell you about their pain remains undertreated, and you get this vicious cycle. So it's something we need to think about in and of itself as a problem we need to treat during the ICU stay. Now, it's unfortunately difficult in the ICU to assess pain, oftentimes due to sedation and mechanical ventilation. There's also multiple sources of pain in our ICU patients: inflammatory, neuropathic, visceral, somatic. But it should be assessed in every patient multiple times per shift in both those who can self-report and those who are nonverbal. And you can assess that with a validated tool. When we're thinking about assessing pain in our patients, just at rest, the sort of everyday basic pain, we can expect about 30 to 50% of all patients, medical or surgical, to rate their pain as moderate to severe just at rest. And then when looking at procedures, which are unfortunately common and required in the ICU, this group looked at 9,000 distinct different procedures in the ICU and surveyed patients about the pain. Most painful was chest tube removal, then arterial line insertion and drain removal, followed by endotracheal tube suctioning and turning. So some of the most basic things we do are incredibly painful to our patients in the unit. Risk factors for these pain at rest is psychologic factors, including anxiety and depression, and then some demographic factors as well: younger age, multiple comorbidities. Pain during a procedure, pre-procedural pain intensity, the worse it is, the more pain you'll have during the procedure. The type of procedure, underlying trauma or surgery, demographic factors, and the use of an opioid prior to procedure. Multiple reasons for this: possibly mistimed opioids, possibly the procedure was going to be so painful it necessitated the use of an opioid beforehand. So how should we assess it if we're going to do it multiple times per day? The SCCM recommends gold standard is the numerical rating scale and self-report. So any pain the patient reports should be treated as fact. So numerical rating scale 0 to 10, 10 being the worst pain, that's the best way to assess it. If you have a patient who's unable to communicate that, then you can use some validated tools. Two of the ones recommended by this FCCM are the Behavioral Pain Scale, or the BPS, and the Critical Care Pain Observation Tool, or CPOT. These take into account facial expression, compliance with ventilator, and tension in the limbs. Once you get a score from one of these scales, then you can decide whether or not the patient needs more analgesia. And then management recommendations. Opioids are usually used as the first line in critically ill patients. We recommend fentanyl, hydromorphone, morphine, and remifentanil. And then, of course, there are non-opioid adjuvants as well, including acetaminophen, nefapam, which is not available in the United States, low-dose ketamine, and then neuropathic agents such as the gabapentinoids. And of course, if you have neuropathic pain, gabapentinoids or carbamazepine. They don't routinely recommend IV lidocaine or NSAIDs in the critically ill population. And then there are non-pharmacologic adjuncts as well, including the ones with the best data are music therapy, massage, cold therapy, and relaxation techniques. And then, of course, the SCCM recommends light sedation and analogous sedation. So there are two different ways you can really achieve analogous sedation. Analgesia-based, where you treat a patient's pain first with a usually opioid analgesic, but then you use that opioid as your sedative as well. So it would be like running a fentanyl drip for pain, but also having it serve the purpose as your sedative. So usually at a higher dose. The analgesia first protocol means that you treat the patient's pain first, opioid, non-opioid adjuvants, and then if you still need a sedative after that for ventilator compliance or agitation, then you can move on to a sedative such as dexmedetomidine or propofol. This group, Dupre et al., found that when they used opioids as this in the analgesia-based protocol, that you had increased delirium when targeting light sedation with these protocols, increased delirium with increasing opioids in a dose-dependent fashion. So something to think about when you're trying to treat pain and find a sedative. So then what about the long-term outcomes? If we know about half of our patients will have pain at rest, our patients will have pain with procedures, we need to assess them, we need to manage it in the ICU, who goes home with chronic pain? We've done a really good job of reducing our mortality rate from down to about 10 to 29%, depending on age and severity of illness. And that leaves us with 70 to 90% of our patients who survive the ICU and have their resultant quality of life. Unfortunately, as we know, there can be derangements in your psychological health and your physical health after your ICU stay, and that's termed the post-intensive care syndrome. And pain can be considered one of those, part of PICS. When we look at chronic pain following critical illness, the studies run the gamut from about 14% to 77% of patients having persistent pain after their discharge from the ICU. Now, this likely reflects not reality, but more a difference in the methodologies of the studies. But it does seem that there is a high percentage of patients that do develop pain after the ICU, and it is more chronic in nature. We did a study where we looked at about 300 critically ill patients admitted to either medical or surgical ICU, and we followed them for 3 and 12 months out and assessed them for pain. At 3 months, 77% of our patients had pain, so mild, moderate, or severe, and 31% of those patients had moderate to severe pain at 3 months after ICU discharge. When we followed them out at 12 months, 74% had either mild, moderate, or severe pain, and 35%, so even more than at the 3-month mark, ranked their pain as moderate to severe. Now, one of the limitations of our study was that we didn't know if those patients at 3 and 12 months who had pain had new pain, or if it was related to the ICU, or they had chronic pain prior to admission. This was answered by Boncyk and his colleagues in Germany. They looked at 200 patients in a mixed ICU, followed them out at 6 months, found a similar rate of chronic pain, 33% in their population, but half of those patients said it was new and specifically related to their ICU stay. So about a 16% incidence of chronic pain after ICU discharge. And then there are a handful of studies looking at this. This is to date the largest one, published in 2020. A group followed patients admitted to a mixed ICU in the Netherlands from 2013 to 2016, and then assessed them for pain 1 year after discharge. They found, of the 1,300 or so patients that they sent the follow-up questionnaire to, 1,100 had no newly acquired pain, but 242 did, and that comes out to a rate of about 17% of new diagnosis of chronic pain related to their ICU stay. And that's in line with the Boncyk study, and that's also similar to some unpublished data that we have from our most recent study. So it's looking like a third of our patients or so are going to have chronic pain afterwards. About half of those patients, it's specifically related to their ICU stay. But how long can this pain last? Well, several studies have looked at the 6 and 12 month marks, so not following out for very long. But one study looked at 575 SICU patients and followed them for about 6 to 11 years. And on average, 57% of patients were still reporting pain 6 to 11 years after discharge. So unfortunately, it doesn't seem as if the chronic pain after ICU really goes away, with the exception of the cardiac surgery population, which is slightly different. And unfortunately, this chronic pain interferes with patients' lives. So in the Boncyk trial, they found 50% of patients with pain said that pain interfered with their life, with their ability to live their daily life, to interact with their family, and to go to work. And our study had a similar proportion of patients, about 62% with pain, said that it interfered with their ability to enjoy life, to go to work, to spend time with their family. And what are some risk factors for this chronic pain? In this large study from the Netherlands, they found that female gender and days with hyperinflammation were the two risk factors that they found. And then if we look at all the other studies put together, we can see that the type of illness, medical versus surgical, didn't seem to matter in terms of a risk factor. High dose opioid exposure, maybe, that was looked at in a couple trials. There's a bit of a signal, but not really statistically significant, probably needs more investigation. Sepsis was equivocal. Days of hyperinflation was associated, but there was a trial that showed no difference with sepsis. There was one that showed there is a difference. Age seems to be a risk factor for this chronic pain. Severity of illness, yes, sicker you are, the more likely you are to have chronic pain. Having a pre-ICU pain syndrome, and then a longer length of stay, and then higher acute pain scores. This is what we logistically think of as what we're trying to fix. If we can keep patients' pain under control in the acute setting, when we have control of it, they should have a lower risk of long-term pain, but we're not actually sure if that is true. We just have to extrapolate from some of the other pain and anesthesia literature. So what are some future strategies around this? Well, first we need to do the things we know are important and right. So improve our compliance in the ICUs with pain assessments and management, and consider using analgesia first sedation practices as opposed to analgesia based. And then we need to further study to better understand risk factors associated with chronic pain. And with that, I think we'll all take questions at the end. Thank you.
All right. Well, thanks all three of you for some excellent talks, and we have some questions in the chat Q&A function. So please, for those that are listening, keep typing those in, and we'll go kind of round robin here to start. First question is for Mike, which is, is there any data on sort of the planned ICU admission, elective person coming in for surgery, et cetera, versus someone who got acutely sick, unexpected emergent surgery or emergent admission, and what the brain function outcomes look like between those two, different types of patients that we see?
Yeah, thanks for the question. Yeah, what I can say is that many studies have actually examined postoperative delirium rates and emergency surgery, and then also elective surgery. There aren't many that have compared them head on, because typically the surgery types and the patient factors are different, and so there are some confounding factors that make this challenging to say what would be the reason that patients would have more delirium after these different surgery types. Specifically, hip fracture compared to elective orthopedic surgery, and then the one that Dr. Agunathan brought up is non-elective versus elective GI surgery that can occur for different reasons. We do know that there is one study on elective hospitalizations versus non-elective hospitalizations in older adults, and that is associated with longer term problems with cognition. I will also say that post-operative cognitive dysfunction studies are challenging in patients who present for emergency surgery. You need to do a cognitive testing panel before surgery and then do repeat cognitive testing after. The before surgery cognitive testing is challenging in someone who has ongoing pain from whatever their acute surgical problem is and systemic illness. So I think it's somewhat of an open question, but from the evidence we have, it is more likely that emergency surgery and even unplanned ICU admission after surgery is associated with longer term cognitive problems, but further studies are needed.
Thanks, Mike. Great answer on that. Second question was for Dr. Boncyk. Why do you think people don't stop the medications? What is there a fear, or is it something in our systems? Like, why do these things keep getting continued?
I think that's a good question. I think part of it is not like most things, it's well-intentioned. People are apprehensive to make changes if they're not going to be that person following up on it. So especially when somebody is leaving your ICU, you're putting them in the care of somebody else. It doesn't seem like the most opportune time to be rocking the boat, especially after you've gotten this patient out of critical illness. So kind of adjusting that risk benefit thing. I think it's a little bit on us. We haven't been, done a great job at really delineating what the risks are for continuation of these medications. We know that they are continued in the non-critically ill population of older adults. We know that there's more problems with these medications, but we're really just now starting to define the risks within the critically ill patient population. So I think as there's more of an understanding of those and the risks associated with it, it'll kind of tip that scale a bit more. But I think probably the most part being, you just got somebody through a big illness. You are a bit apprehensive to make any changes before you put them out into someone else's hands.
Gotcha. Dr. Hayhurst, if the question from the chat, so is there a link between people having pain and maybe less functional ability because of that pain and cognition after ICU stay?
So unfortunately, I don't know that we have any data linking those two things. We do have some data linking delirium and agitation and pain in the acute setting, but unfortunately, chronic pain specifically related to ICU is very understudied. So kind of the best we have is the incidence of it, some of the risk factors, not all of which agree. So I don't think we know if those patients with chronic pain are also the ones who develop cognitive dysfunction, but it's definitely an area that could be explored for sure.
Thank you for that. Cycling back up to Mike. So COVID and all the difficulties with COVID and visitation and different things, has there been data on what does that look like for delirium risk and things in the ICU?
Yeah, absolutely. Actually, I think at Vanderbilt, a study by Brenda Pun and a group there with Pratik Pandiparande, they did I think it's a multi-center cohort study that looked at factors during the COVID pandemic associated with delirium. They found a large burden of delirium, and they found that ICUs that did not allow family presence, or if the family wasn't allowed to have family presence, then the patient was more likely to be delirious. So I think there's some decent evidence showing that that family presence is really important, and it impacted delirium rates and potentially even severity in our ICUs. So I'm glad that most ICUs have now gone to allowing family presence again. Thank goodness.
Tina, prescribing strategies maybe up front that can prevent, anytime you say multidisciplinary, everyone I think gets scared. That's going to be a lot of work, or it's going to be hard to coordinate. So is there something that we can do maybe up front, either through the EMR or just processes that would maybe provide some protection from these things being continued?
I think there are. I think the first thing really is stop dates. A lot of these things are continued just because they're continued indefinitely, but really emphasizing the importance of stop dates. We do it for antibiotics. With our antibiotic stewardship, it's really been ingrained in us to identify stop dates, but I don't know that we do that for the other medications so much yet. So a lot of these medications are initiated for insomnia or anxiety or other non-chronic conditions for patients. So being able to identify those stop dates on those as well. And then I also think some of the things coming out with the EHR is dose adjustments, especially for older adults, where the same doses that might be used in younger patients could be automatically, optimized or populated in the EHR to be decreased in patients over a certain age. Although our ICU patients, a lot of the times physiologically behave the same as older adults with decreased physiologic reserve and organ dysfunction. So I think some of the doses and the endpoints could help with decreasing those prolonged administrations for patients as part of a bunch of other things.
All right. Thank you, Tina. And then Christina, one of the questions in the chat was about sort of the types of pain that people are reporting. Is there certain characteristics that's common for our patient population after ICU?
Yeah, I think this is a really interesting question because it's sort of pain you might not expect. So one of the studies looked at the location of pain, and it was ankles and shoulders. And so it seems like maybe it would be incision sites, things like that. But if you have a prolonged stay in the ICU, you're immobilized for a long time. It appears that if you have shoulder subluxation or you're developing a sort of foot drop, you end up having lots of pain in those locations 3 and 12 months after discharge. This particular study was looking at 6. There was a study looking at COVID patients and their healthcare related quality of life published in JAMA. And they found a year after a COVID ICU admission, the patients were having joint pain as well. So it's interestingly kind of, if you don't use it, you lose it, lots of joint pain. There's also lots of inflammatory pain that patients are still having, but it's interesting because these are the types of pains that are more difficult to try and treat with our regular analgesics in the ICU. So throwing more opioids at a foot drop is probably not going to help in the long run. So things that we have to keep in mind with different treatment strategies in the acute and long-term situation.
Thank you, Dr. Hayhurst. Back up to Mike. So question about using sedation and sedatives, or maybe even analgesics, but for controlling respiratory drive. I think that's got a lot of attention here recently with COVID. So that interplay with sedation, but also vent compliance, et cetera. Can you talk a little bit about that? And maybe there was a question about dexmedetomidine too from Bev or that we can combine into that if you think that reasonable, or we can approach that one.
Yeah,
later.
I think COVID definitely presented a challenge for the management of sedation, and honestly, oh yeah, definitely. So I think COVID presented a lot of challenges in terms of management of sedation. We really had to oversedate many patients to adequately control their respiratory mechanics and provide enough oxygenation. And that was a problem because you were kind of weighing the risk to the brain versus the risk to the lungs and other organ systems. And I wish we had better data on how much risk to the brain there was with over sedating patients to control the respiratory drive, and that would help us make an informed decision. I absolutely think that really using multiple sedatives like we were, benzodiazepines plus propofol plus, and adding on neuromuscular blockade definitely resulted in some cognitive and physical impairment in our COVID patients post-ICU. And I think that we need to maybe recognize the risk to the brain more and try to basically remove the sedatives as fast as possible, as when the lungs are starting to improve. And it's definitely a challenge. And to kind of get to Dr. Orster's question, and I probably should have referenced the MENS 2 study because Dr. Hughes is moderating this panel. But dexmedetomidine is a great sedative agent. Propofol also is really not inferior to dexmedetomidine, and so dexmedetomidine for sedation in the ICU should be used to produce light sedative states and keep the patient comfortable. I don't think that we can say that we need to use dexmedetomidine on every patient. I think achieving a light sedative state with either propofol or dexmedetomidine is a reasonable practice until we get further data. So my recommendation is to target a light RAS of 0, no lower than a RAS of -1 in our patients.
Thank you, Dr. Devinney. And Dr. Boncyk, I wanted to maybe if you can give some recommendations to the group or suggestion about like how do ICU providers link then to post-ICU providers or post-hospital. We're coming up with all these impairments or all these issues, but then we don't have a reach out there. So how would you suggest that happens?
Yeah, and I think that deficit was definitely highlighted by the COVID pandemic with just the sheer number of patients that now are, kind of just being released back to their primary care providers that don't have, maybe the most recent understanding of what had happened to them within the ICU, and could be within a different hospital system. We received a lot of patients from across states and accessing their medical records and whatnot. It's definitely a disjointed system. I think probably the best tool in a hospital system or outside of it is documentation, which is also the hardest thing when you're overwhelmed with numbers of patients, but really putting down the indication for it. I think another thing highlighted on the medication reconciliation on the front side was a common practice of what patients are taking and how they're taking them. A lot of the times that the medications that are given are in PRN form, but you can ask a patient and they take it 3 times a day, every day religiously. So I think a little bit, understanding and education about how those prescriptions should be given, but then the indication of why. And without understanding why they were started or why they were continued, there's always a risk of discontinuing medications. But for the most part, patients can be weaned off of them or transitioned less if there's no longer indicated. And you would expect that over time in most of these patients, in months to years after an ICU discharge, they're not going to be needing those same medications, or they hopefully shouldn't, or they could have, doses of changing. And so outside of, I guess, recommending that every hospital is able to, source and fund and staff a post-ICU clinic, it has to be a little bit, dependent on the documentation and the chart transfers among providers.
Because all of us have a lot of funds to start up any sort of new program we want, right? Especially nowadays. Christina, I want to ask you about if there's any specific pain meds. You talked a little bit just about sedation or just pain in general, but is there any specific medications in the ICU or maybe use of regional anesthesia in the ICU that's been associated with better long-term pain outcomes, chronic pain?
I wish that these studies have been done, but to my knowledge, they haven't been done yet. So I think regional anesthesia is really underutilized in the critical care population. I would say we probably do epidurals for thoracic cases, but at least at Vanderbilt, they don't even come to the ICU. We did a sort of QI study a couple of years ago looking at regional blocks for burn ICU patients that were having donor sites taken. We did a regional block for those, looked at their pain afterwards and then their opioid use during their immediate postoperative period, and found that the blocks improved that, but we don't have any long-term data either. So I think there's so many plain blocks that are being used. We're starting to use a lot of PEX blocks and things like that, or parasternal blocks for post sternotomy patients, things like that. I think there's a lot of ways that we could start using more regional anesthesia. Unfortunately, no data in the chronic pain literature for that for specifically related to ICU.
And then maybe just one follow-up question. Do you think it's underutilized as an anesthesiologist who covers our peri-op service and other things and our ICU? Do you think regional is underutilized for ICU patients?
Yeah, absolutely. I think regional could be used for a variety of things. Unfortunately, the problems are you have to, if you want long-term pain control, you'd have to have a specific location. You would have to be able to tolerate a local anesthetic, and then you'd have to be able to tolerate the risk of having an indwelling catheter. You know, in our ICUs, we do that all the time in terms of central lines and things like that, but we think of those as necessary for vasoactive agents or monitoring, et cetera. And some people might think of a regional pain catheter as maybe less necessary to the keeping the patient alive when you're just maintaining pain control. So I think it is underutilized. I think a lot of the recommendations from the big societies are also taking into account multiple patient populations. So probably a MICU patient is not going to benefit as much from a regional catheter as maybe a post-surgical patient. So something that we could really investigate in the more surgical population.
Thank you for that. And just to let everyone know, it is 4 o'clock. We will continue with a few more questions and go past, it's 4 o'clock where I am. How about that? Or it's noon somewhere. But we will continue for a little bit longer. And then if there's other questions that we don't get to, we can also do that through emails. But thanks all for joining for this hour. So I guess one of the getting towards the last questions. Do you think if you're doing these light sedation strategies that you're recommending, do you still need to also then do an SAT, a spontaneous awakening trial, or daily sedation interruption trial?
That's a great question. So I'll preface it by saying that there has been a study on no sedation versus light sedation in terms of outcomes. It really should not show any effect of mortality with light sedation compared to no sedation. So the urgency of decreasing, from light sedation to no sedation is not there. But your question was more, should we perform daily interruptions? And I would still say yes, because you still want to show that the patient needs to have that light sedation. I think as clinicians, we also need to weigh the risk versus the benefits. If it's, decreasing the sedation when someone has, life-sustaining lines like ECMO catheters in place that they, maybe they've had, chances of pulling out before they've went after them before, and light sedation's working well, you certainly could skip some of those interruptions, but I think that they still have some utility in terms of showing whether the patient needs those. And they may be, our sedative agents may be affecting our patients in hemodynamic ways or other ways that could be revealed with those interruptions. So I would say we should still do them, but the urgency is less because the outcomes in light sedation versus no sedation are similar.
Thanks for that. I guess it probably also maybe allows you to do some either stuff with the family or PTOT during those sedation interruptions that or at least maybe take them even a step further. Tina, I'm going to throw this one towards you. So there was a question earlier on in the chat about measuring delirium in the neuro patient population or people with, I would say, stroke or TBI or different type of neuro insults. Can you comment about, what's out there in that regard?
Yeah, we have a active neuro ICU, trauma ICU, and so done a bit of investigating on this. And the probably the most common tools used in those neurocritically ill patients, either with traumatic brain injuries, strokes, etc., are the CAM ICU and the IDCSC. And the CAM ICU probably has the better data. Both aren't robust in their findings, but once you're able to establish what the new baseline is for patients after their neurologic insults, those tools are still valid and able to use. We've also looked at, the incidence of, missing delirium by not screening versus potentially over-calling delirium. And it definitely is in favor of, not missing those patients and making sure that you're in tune, because the risks of missing out on those would outweigh the risks of any risks for potential overdiagnosis of delirium, especially in the neurocritically ill.
So you mean the Q1 hour neuro checks for 14 days in the subarachnoid hemorrhage patient population is
That's a
Harrison
whole
Cam
other
ICU,
topic.
but some Cam ICUs with those as well, huh?
Few things should be Q1 in life, but
All right, and then maybe our last question is about systemic inflammation and its role in chronic pain in ICU patients, and both those to Dr. Hayhurst here about, you know, what literature is there. How do we even tease this out with everything else that's going on?
Yeah, it's a good question. I think most studies have tried to use a surrogate for inflammation, looking at sepsis as sort of their surrogate. And one study found that sepsis was an independent risk factor for chronic pain after ICU. One study, and these were both small-ish, found that it was not. So kind of conflicting data there. And then the large study that had the 1,300 patients found days of hyperinflammation with an elevated marker. So sort of more strict measure with the CRP was a risk factor for chronic pain. So it seems as if it probably is, and teasing it out is probably going to rely more on those biomarkers than by using sepsis definitions. So whether or not you can, that is just going to be something that you have to treat the underlying cause. That's probably going to be most likely, not likely to be able to be treated with any sort of anti-inflammatories, unfortunately.
I think one of the, maybe just to add on to that, one of the things we are looking at, or I think is a new field of investigation, is these people that have the persistent inflammation. So we think a lot of these impairments are from, you know, the acute inflammatory insult and leading to neuroinflammation, et cetera. But that should resolve. And so people that continue to have that inflammation may have the brain dysfunction, or maybe have the muscle dysfunction, or maybe it's the pain. So how do you tease out the ones that have that continued hyperinflamed state as opposed to resolving it in a timely manner? I do have one more. I don't know if I'm going to throw this to Mike's. If you know, are there any differences in the incidence of ICU delirium across different ethnicities?
The Indiana University group, I think, as Barbara Kahn had a study, they actually showed that there was no difference. I think some of the perioperative studies have shown African Americans to be at a higher risk of delirium. And interestingly, some of the cohort studies just on older adults in general have found higher inflammation in older African American adults. And so, you know, that could play into potentially higher risks of delirium. But in the ICU population, maybe there's a bit of regression to the mean in terms of inflammation based off of you know, ICU insults. But I think further studies are needed. The study by Indiana was smaller, and I think we need to do a better job of kind of recruiting diverse populations into our studies.
Great answer, and thanks for that. I think we've got most of the Q&A sessions. We're coming on to 10 minutes over. So I just wanted to say thank you to our three panelists for awesome talks in a Q&A session. Thanks for those who joined us and who listened to this later on recording. Appreciate these IARS webinars have been really a great, really a great venue for these. Getting some, I think, new information out to a lot of people, and stimulating conversation and question and answer sessions. So thanks to everyone for joining. Thanks again for panelists, and we will see you on the next one.